Well, hello everyone, and welcome to our second All Things Celiac webinar of 2026. This series is brought to you by the National Celiac Association and the Harvard Medical School Celiac Education and Research Program. Today's topic is Navigating the Change, Optimizing Midlife Health for Women with Celiac Disease. My name is Chris Rich, and I am the CEO and Executive Director of the National Celiac Association. At NCA, we provide educational resources to our celiac community, such as this All Things Celiac webinar series, and we value the opportunity to continue this work in collaboration with the Harvard Medical School Celiac Education and Research Program. In addition to our educational programs, the National Celiac Association offers an extensive support network that reaches from coast to coast, and we provide information for individuals of every age, gender, race, and background. In addition to being the voice of our community, we help people who face food insecurity using our Feeding Gluten-Free program, which works to provide gluten-free food directly to food pantries nationwide. You can find more information about what we do and how you can support NCA's mission on our website at nationalceliac.org. The highly collaborative Harvard Medical School Celiac Education and Research Program was founded in 2013 and has a twofold mission of developing and promoting the latest research in celiac disease and advancing awareness about celiac disease through educational programs to clinicians and the general public. Education is at the heart of the HMS Celiac Education and Research Program, and these webinars continue to feature multidisciplinary speakers with specialized knowledge on celiac disease, related autoimmune conditions, and nutrition. Today's session is being recorded and will be available for viewing on the National Celiac Association's website at nationalceliac.org. On our site, you can select the Resources tab from the drop-down header menu and click on NCA Webinars. From there, a tab will link you to the entire All Things Celiac webinar series. The recording of today's session will appear there in approximately 5 to 7 business days. Our moderator for today is Dr. Katherine Olshan. Dr. Olshan is a pediatric gastroenterologist at MassGeneral for Children. She serves as an assistant physician at MassGeneral Hospital and as an instructor at Harvard Medical School. She is a member of the Center for Celiac Research and Treatment at MassGeneral for Children and is involved as a sub-investigator in multiple clinical trials currently enrolling participants with celiac disease. In addition to her medical degree from Medical College of Wisconsin, Dr. Olshan completed her residency in pediatric medicine at the University of Massachusetts Medical School, UMass Memorial Medical Center. She also completed her fellowship in pediatric gastroenterology at Mass General for Children. So we'll get started today with welcoming Dr. Olshan.
Thank you so much, Chris and NCA, for having me here today for this really exciting topic. For all people listening, and we do have a Q&A feature available. If you have questions, in addition to ones that were submitted prior to today, feel free to type those in throughout the presentations, and we will address as many as we can at the end during our Q&A session. We ask that these be general questions only and not contain any specific medical information. CEUs are available for registered dietitians, nurses, physicians, and social workers. There's a new system for claiming the CEUs, so please watch the chat for that information. Now it gives me pleasure to introduce our first speaker. Dr. Maia Sharuk is a Massachusetts native who completed her undergraduate work at Wellesley College and her medical degree at the University of Massachusetts. She completed her residency in OB/GYN at Bridgeport Hospital, Yale New Haven Health, and then returned to Boston, where she worked at Atrius, Harvard Vanguard, the general OB/GYN from 2015 to 2022. She joined the ASCOG division of the BIDMC in 2022 and credits her mentor, Dr. Martha Richardson, for sparking her interest in menopause and women's midlife health. Her goals include providing care to patients during the menopausal transition, as well as improving education for healthcare providers in women's midlife health. Thanks so much for joining us today.
Thank you, everyone, for having me. I'm just going to share so I can provide some information as I chat about understanding the menopausal transition. All right. So just to go through my disclosure, sadly, I have none. As Dr. Olshan had mentioned, I'd really love to credit my mentor, Dr. Marcy Richardson, for both my own education and contributions. A little special note before I get started, I may at times use the term women to reference any patient with ovaries in this presentation, but this does not only include women. Again, this all includes all human beings who are born with ovaries. The objectives that I'm going to try to talk about here and hopefully get through it is review some definitions of perimenopause and menopause, review some symptoms one may experience, and hopefully give some options for managing menopausal symptoms. And I will have some resources at the end. And if we don't get to them, I will make sure that they're available for everyone to see afterwards. So I always like to start off that, the interest in menopause and the menopausal transition has really increased in the last 10 years. Just a gentle search on people looking up menopause has really just skyrocketed. So let me talk a little bit about perimenopause, and the what and the when. So historically, we used to think perimenopause was a very specific time during our hormonal transition. We used to say that patients who were perimenopausal had very irregular cycles, that the age of onset was somewhere in the late 40s, and that most people had things like hot flashes, night sweats, or sleep problems. But the actual things that we're learning nowadays is that things are a little bit more subtle and things are happening a lot earlier. The first changes in the cycle can be very subtle, where things are only off by a few days. It can start as early as the late 30s or even early 40s. And the symptomology is a lot wider. It can include mood changes, feeling forgetful, irritable, down, tired, nervous, anxious, in addition to having sleep problems and hot flashes. And even the definitions of perimenopause also seem to be changing. We stress that these changes can be subtle, cycles can become a little bit shorter, and the number of days of bleeding can vary. It can either be fewer days, it can be more days, it can be lighter, heavier, more frequent. So the definition is really shifting, and it can be very subtle and very individualized, which I think is really important for patients to know. And so, what have I heard experiences wise for what patients are really feeling is new? Patients will come in telling me, I'm not sleeping like I used to. I wake up at like 2 or 3 in the morning and I just can't get back to sleep. I feel more anxious. I can't cope with the same things that I used to. I get more overwhelmed. Or I've become so irritable that I'm snapping at my family. I just don't feel like this is who I am. And so, is this perimenopause? Is it not? Does it matter if somebody's 40 years old, 42, 38? And what if we still have regular monthly periods? Does that still mean that we're not perimenopausal? But in actuality, one of my colleagues who runs a wonderful website called Women Living Better did an amazing study which surveyed hundreds of patients about how they sought health care regarding some of these symptom changes in their 40s and 30s, and what their experience was and what those symptoms were. So here's a little bit of information of what we learned. So this study had about close to 1,000 participants. It included both satisfaction and dissatisfaction. And the trends that we saw is that patients felt very dismissed. People that said that they were told, "Oh, this is not perimenopause. You're too young for this to happen." Or they were told that the discussion was just not worth even having, which is extremely unfair. And I would definitely say advocate for yourself, because if you notice there's a difference, there's probably a difference. And so patients who continue to have regular symptoms in our study, what we saw is that patients experienced a wide array of symptoms: more forgetfulness, irritability, low libido, breast changes, fatigue, anxiety, waking up in the middle of the night, feeling overwhelmed. And then towards the bottom is where we saw the hot flashes and the night sweats, which everyone historically thought was what's going to be the biggest symptom. And so if you start to notice some of these differences, you should definitely be bringing it up to your providers or working with a provider who is a specialist in menopause and perimenopausal care. So when do we really think perimenopause begins? When our patients have actually noticed a difference. And so for some people, it's before there are really obvious changes in one cycle. And as clinicians, it's our job to really understand, listen to our patients, figure out how we can support them, because this transition, it's not easy. And there's the part with perimenopause, and then as we approach that menopausal transition, it tends to get a little bit worse. So I'm going to get a little bit into the actual menopausal transition and hopefully get a little bit of time to talk about hormone therapy as well. So going through a couple of definitions, mostly because we do feel semantics kind of matter sometimes. But menopause itself is a natural process, really defined as no longer having periods for 12 months or longer. And this is really due to what we call ovarian follicular function, meaning that our ovaries are really retiring from producing eggs for reproduction. If you hear me say the term or see the term FMP, that means our final menstrual period. And then premature menopause is someone who has a final menstrual period before 40 years old. Early menopause is a final menstrual period before 48 years old. And the term for menopausal transition is just kind of the time frame around menopause, where patients can be both in their late perimenopausal phase into the post-menopausal phase. The reason I think it's important to know about the differences in timing for premature and early menopause is we do know that patients with autoimmune diseases, including celiac disease, have a little bit of a higher risk for going through menopause at an earlier stage. Still kind of trying to understand why that happens, but it is important if you are noticing symptoms starting earlier in your late 30s, early 40s, knowing that if you do carry a diagnosis of celiac disease or even other autoimmune diseases, you may be at risk for things happening earlier. And so it is very important that, you feel like you find a provider who is listening to your concerns. And we also have a little bit of an evolving name with when we talk a little bit about hormone therapy. Historically, people have referred to this as what we call HRT or hormone replacement therapy, and then kind of converted into hormone therapy. And now we tend to use the term what we call menopausal hormone therapy. So really the reason for this kind of change in these definitions is that menopausal hormone therapy really it's used as that term to reflect that we are using hormones to treat symptoms rather than just trying to replace hormones back to their premenopausal level. So menopausal hormone therapy is the use of estrogen with or without progesterone, depending on the patient, to treat those menopausal symptoms. When we use the term hormone replacement therapy, this is more in reference to patients who may have undergone premature menopause, where we're truly replacing needed hormones that are inappropriately low or missing. For example, patients who may have undergone a surgical menopause, meaning they had their ovaries removed for a surgical or genetic reason. At an early stage, those patients, we need to replace those hormones that are so needed at such a young age, rather than menopausal hormone therapy, which is more for kind of that natural transition that is to help with the symptoms of the transition. So let's talk about some of those symptoms, which we slightly alluded to in the perimenopausal section, but a little bit more of what patients will then start to notice even more intensely as they approach their menopausal transition. So the first that is most classically known and probably more well-known is what we call the vasomotor symptoms. And this includes your classic hot flashes and night sweats. Patients may also start to develop, as I mentioned, irregular periods. Patients will notice vaginal symptoms, including vaginal dryness. Sleep disturbances become a little bit more heightened. Mood changes, what we call cognitive changes or brain fog, weight gain, low libido, skin and hair changes, joint pain, and the really classic that I get all the time, not really feeling like myself. So let me talk a little bit about those vasomotor symptoms. So this is the most common symptom, or the most, I would say, obvious that patients really know is part of their menopausal transition. And this includes daytime hot flashes and night sweats. The description of the hot flash really is not just like feeling overall warm. A hot flash also includes a like deep sense of heat in both the upper body, which is the chest, neck, face, that really kind of climbs up into the face, can be associated with extreme sweating, followed by rebound chills, nausea, heart racing, palpitations, and even a sense of anxiety. And they can last anywhere from 30 seconds to 5 minutes. They tend to be the most intense in what we call like the late perimenopausal phase and into the early postmenopausal phase. Sleep disturbances are also one of the most common complaints that patients have. And this can be both a difficulty in sleeping, but also can lead to even the full disorder of insomnia. Most patients who do have vasomotor symptoms, which are hot flashes and night sweats, are also going to complain of sleep disruptions because a lot of these can wake one up from their sleep. But sleep disturbances can also happen in the absence of these symptoms. So patients will wake up even without a hot flash or a night sweat and say that they're waking up in the middle of the night and can't get back to sleep. Close to 40% of patients in this age range will complain of this difficulty in sleep. And while there are some other contributing factors, sleep apnea, thyroid problems that can also cause sleep problems, sleep disturbances is also one of the most common complaints that we get for our menopausal patients. Cognitive changes, or what we call brain fog of menopause, is also extremely common. It tends to be, again, mostly in the late perimenopausal phase into the early menopausal phase. Patients really describe a decline in like processing speed of tasks that they're given, more forgetfulness, word finding problems, difficulty concentrating. But interestingly enough, the ability to learn new tasks is not as affected. A lot of patients, whether they've been treated or not, may do tend to notice an improvement once they have gone into that more later menopausal phase, like several years out. But it tends to be an extremely disruptive part because patients feel like it really does affect their ability to function, both with their family, but also in their jobs as well. The next symptom that is also very common is what we call arthralgias, which is the arthritis of menopause or joint aches. Patients can experience increased muscle pain, joint problems, and even arthritis-like symptoms. About half of patients will describe these symptoms that are extremely bothersome. We do know patients who are a little bit maybe have a higher BMI or a little bit less active, may have a little bit worsening of this. But honestly, it really can happen to anyone going through this transition. So what can we do about this? All right. Right now, the FDA has approved menopausal hormone therapy for these following indications. So hot flashes and night sweats, for the prevention of bone loss or osteoporosis, not treatment, the treatment of what we call premature menopause, and what we call the genitourinary syndrome of menopause, which relates to the vaginal dryness and vaginal changes of menopause. That being said, we really need to think about individualizing therapy because a lot of our patients may struggle with other symptoms, including the ones that I discussed, without having one of these indications. And so that's why, even though things are not FDA approved for maybe the symptom that someone is feeling for menopause right now, it is really important to have a conversation both with the provider and the patient to really understand how we can help, because for some patients, menopausal hormone therapy really helps a lot of these symptoms. And so we can't just think about only treating these ones that are just currently approved.
2 minutes, Dr. Sharuk, 2 minutes.
All right, I'm going to try a little bit just to talk about the types of hormone therapy, and then I'll turn it over to my colleagues here. When we talk about hormone therapy, we're really talking about giving back some estrogen because that is what the major drop of hormone that we're having during this transition. Estrogen alone therapy is done for patients who have had a hysterectomy. And then for patients who still have their uterus in place, we do a combined estrogen and progesterone. The most commonly used form of estrogen, while I'll have these up here, the most is that first one we call micronized 17-beta estradiol or estradiol. This is a bioidentical formulation that we tend to give and most widely used. They can be given both orally or transdermally. I will say just quickly, so I can give a little bit about progesterone as well, is we tend to favor a transdermal route if possible. The reason is that it is not metabolized by the liver. When you take things orally, it does have to go through that hepatic or liver metabolism, which is where some of the risks of estrogen do come into play. When it's metabolized by the liver, it can increase clotting factors, cholesterol levels. And so that's where we can see an increased clotting risk for patients who may take it oral, which is why we try to favor a transdermal approach, which is usually in the form of a patch or can be a spray or a gel. For progesterone, real quick, as I mentioned, we need that progesterone if we still have a uterus because we need to protect our uterus. The lining of our uterus really requires a delicate balance of estrogen and progesterone. And if we have that unbalanced where estrogen outweighs it, we can actually grow some abnormal lining inside the uterus, which can cause bleeding, spotting, polyps, and God forbid, if really untreated, can turn into precancer or cancer of the uterus. We have a couple of different forms of progesterone that are available. Most commonly used is what we call micronized progesterone. This is also a bioidentical form of progesterone, meaning it's the same form that our body makes. But we also have other forms called progestins that are a little bit more potent that can really also be very protective for the uterus as well. We have different ways that we can give progesterone. It can be given orally. It can be given in the form of a progesterone IUD. There are some combination patches as well that are available. As I mentioned, there are some transdermal alternatives for the estrogen that I just wanted to kind of share here as well. And I would have loved to been able to have a little bit more time to talk about some non-hormonal options, but I'll try to be able to share some of my slides so that if patients do want to take a quick peek at them, and maybe I'll be able to answer some questions about non-hormonal options in the Q&A. So thank you guys so much for listening. I don't think I've had to try to give that talk in such a short time span, so I'm sorry that I didn't get to give as much information as possible. We have some great information coming up from my colleagues here.
Thank you so much. That was really information-packed and really helpful. So thank you for taking the time. We appreciate it. Next, I'd like to introduce Dr. Jacqueline Wolf, who's an associate professor of medicine at Harvard Medical School in the Division of Gastroenterology at Beth Israel Deaconess Medical Center. For over 20 years, Dr. Wolf has focused on clinical practice, scholarly activity, teaching, and clinical research at the intersection of women's health and gastrointestinal disorders in women. She served as the GI representative to the Society for Women's Health Research Medical Health Advisory Board and later served on its board of directors. She founded the Women's Digestive Health Center and a Women's Digestive Health Fellowship track at BIDMC, bringing together GI subspecialties that focus on conditions affecting women differently or influenced by reproductive health cycles, including celiac disease. Dr. Wolf is the author of A Woman's Guide to a Healthy Stomach, Taking Control of Your Digestive Health, and has also written book chapters for lay audiences, developed nutrition resources for GI patients, and created educational content on diets and cooking for ABC News, and developed nutrition handouts for GI patients, including patients with celiac disease. Thank you so much for joining us today.
Thank you. It's very nice to be here. Thank you for inviting me. And this is a really important topic as we go through our life cycle, we move from problems when we're having symptoms with our menopause, with our menstrual cycle and premenstrual cycle, to perimenopause and then menopause. Next slide, please. Thank you. I have no conflict of interest for this talk. Next slide, please. So I wanted to give the learning objectives, and there were a number of questions already put before this webinar, and I think I was going to answer most of them, and I tried to get answers to those that I didn't have answers for in my talk. So how hormones affect the digestive tract during the normal menstrual cycle. What happens to the hormones in perimenopause and menopause, and we just heard about that. What happens to bowel function in perimenopause and menopause, and this affects all women and not just those with celiac disease. Do the hormones have an impact on celiac disease? Does celiac disease have an impact on premenstrual and menstrual symptoms? And how do menopause and perimenopause affect bone health? And how does celiac disease impact it? Next slide, please. Just to start, I will say there are not a lot of data on these topics, and much of the data is based on very small studies. This looks at the normal variation of your menstrual cycle. And people usually say that after you've ovulated and you go to before your menstrual cycle, you get a transit time of firmer, harder stools and bloating. And then as people have their periods, they get looser stools and abdominal cramping and pain. And many of my patients who have constipation often were very relieved to get their periods. Next slide, please. So what happens with the estrogen in the menstrual cycle? And it also is impacted by whether people have irritable bowel. These are just control people on the bottom line, and the top two lines are people with irritable bowel syndrome. And you can see that as they go towards they have more symptoms all of the time, but as they go towards their periods, they get more abdominal pain, bloating, and the intestinal gas is still there, but in the controls gets decreased. They have, more, as I said, more frequent stools during menses. Next slide, please. So this just looks at, again, and you just heard the talk about perimenopause and menopause and the age we're talking about. And we just learned about what other things overlap with irritable bowel, with menopause, and we're going to see one study looking at what happens in celiac disease. Next slide. Well, what does happen? Estrogen causes slower stomach emptying. Progesterone can cause increased gastric emptying, and testosterone really has no effect. On the colon, estrogen delays motility again, and progesterone may delay also motility. Next slide. Well, one of the major things that people have talked about lately is the gut microbiome, and I think that ultimately, maybe not in my lifetime, but in your lifetime, we will see a way that we can individually modify our gut microbiome, and that may help our GI symptoms, our cardiac health, our cancer risk, and all sorts of other things. But looking at, there are bacteria in our gut, and they secrete a number of substances. They secrete short-chain fatty acids, the most common being acetate, propionate, and butyrate, that decrease inflammation and regulate gut motility. These often secrete this beta-glucuronidase, which is really important for our estrogen cycle. and beta-galactosidase, which is important for bile acids. So as we go through our menopause, perimenopause, and we get older, these bacteria change. And what happens in our gut is the estrogen is not made into free estrogen, reabsorbed into the circulation, and it gets excreted more in the stool. In young people, these bacteria help reabsorb the estrogens into the bloodstream, and we can get conjugated estrogens that will then be active and not secreted. In men, we still have a different estrobolome in menopause as compared to men. And again, I don't think we know what happens to the estrobolome in people on testosterone and with other gender identities. Next slide. So testosterone starts declining at the age of 35. Progesterone starts declining. Pelvic floor and other muscles weaken, and we'll discuss that. And there's risk of pelvic organ prolapse, and it rises with increasing age, and it impacts everyone, including those with celiac disease. Next slide. During perimenopause and menopause, and I could not get the original study for this, we can only get the report, is that they saw that 94% of patients had digestive health symptoms with bloating, constipation, stomach pain, and acid reflux being most the common, but only a third of people had a diagnosis of irritable bowel syndrome. So perimenopausal GI symptoms are unclear, but in menopause, people have a lot of symptoms. Next slide. So this looks at NHANES data, which is a big database, and it looks at overall postmenopausal women had an increase in both chronic constipation and in chronic diarrhea over those who were premenopausal that you see in the blue. Next slide. This is looking at your Bristol Stool Form Scale. You've heard about this, you see it online, and what does it mean? Well, it's constipation in type 1 and 2, it's diarrhea in type 6 and 7, and these are just normal. And you can see what normal can be, and you see the description there. People will ask you when you go to your doctors what type of stool that you have, so you can explain your symptoms. Next slide. So constipation is a condition in which you may have fewer than 3 bowel movements a week, stools that are hard, dry, or lumpy. They're difficult or painful to pass your bottom, and a feeling that all stool has not passed and it's just sitting there. Next slide. So what does this mean? Well, in men, and I'm going to show you this, these are men less than 45 or men greater than 45, that they do not have really a change in irritable bowel syndrome symptoms or gut-brain disorder. But women, as they get older and are postmenopausal, do. And many of these IBS slides, I'd just like to thank Dr. Judy Nee for her providing these slides. Next slide. Well, this is also important, and people don't talk about it. They're talking about it more online. But how do you get the stool out of your bottom? And this is at rest, and you can see you have a contracted muscle here, the puborectalis, and you have a big angle coming down. There's tightness here in your anal sphincter. And when you try to eliminate, this muscle relaxes, the rectum goes straighter, and you're supposed to get it relaxing there. Next slide. But that doesn't always happen. And what happens is people feel they can't get their stool out. So with chronic constipation, what we often see is that anywhere from 1/5 to 4/5 of people can't get their stool out and have obstructed defecation. It's 3 times higher in women. There are many factors that can be associated with this, and it can also be people can have their stool is leaking out because they can't get it all out. And it can really affect the quality of someone's life. Next slide. So just for all of this, and to keep in mind what you can do for your constipation as you get older and find that this is a problem, or even now if you have it and aren't older, you can try bulk forming agents. You can have psyllium, aspergilla husk, benefiber. Some people use Citracel. Metamucil or psyllium is the best studied for this. If that doesn't work, we often talk about osmotic substances, magnesium oxide, hydroxide, or citrate at 400 to 1200 milligrams per day, and Miralax, which you really have to take about daily unless you get too much going on, and you can modify it from anywhere from a half a capful, which often doesn't work, but 1 capful up to 2 capfuls per day. There are also stimulants, which is Dulcolax or Senecot, Smooth Move Tea, some of the herbals, and you can also, and if it's getting stuck in your rectum, then many people will use glycerin suppositories, Dulcolax suppositories, and sometimes people have to splint to get the stool out. Next slide. So what about in perimenopausal and postmenopausal stage in celiac disease? What you can see here is in celiac disease, often they will have a shorter menstrual cycle. There may be premature menopause. You can see here and up with those with celiac, 1.4% versus those without. There's irregular, and then in pain associated with the menstrual cycle before you go through menopause, it may be increased. And menopausal and perimenopausal symptoms are also more common. Next slide. The arrows show you that the associated symptoms that are more common in menopause that you see in those, this is the untreated celiac disease group, and this is a treated one that's been treated for over a year, and in many of these studies, it's over 2 years. I want you to pay attention, though, when I show you these studies, there are very few participants in it, and that's the problem with all the studies. But hot flashes were more common in the untreated celiac disease group, maybe not in the treated, it's about the same, a little different. Muscle joint problems is markedly increased in the untreated celiac disease group, about the same, but in the treated celiac disease group compared to controls. And irritability that you just heard about also is increased in the untreated group. And also you will see here, this is putting everything together with irritability, bladder problems, and other things. Next slide. So what about the fertile lifespan? And you heard that it may be different, but it is thought in those with untreated celiac disease, these are the years, and this is when you go the age of menopause at 50 here in the untreated group, 47. It's almost the same in the treated celiac disease group. And the age of menarche may also be different in celiac disease. Next slide. So what about bone mineral density in celiac disease? And I will tell you that a lot of these studies don't totally agree with each other. And part of it may be from where they are being done, what groups are included. Many of the studies only had white participants, European participants. We don't have a lot of data on other groups. So 40 to 70% of the people with celiac disease have a bone mineral density lower than one standard deviation below normal. 21% were first diagnosed after the diagnosis of osteoporosis and 9% after fragility fracture. There's a strong correlation of age at menopause and bone mineral density at the lumbar spine, but not at the pelvis and the femoral neck. This has been very controversial. Melinda, is there an issue?
Oh, just giving you a 2-minute warning right now. Thanks,
Oh, thank
Dr.
you.
Wolf.
And gluten-free diet in the first year of diagnosis leads to an increased bone marrow density. And I will quickly show you those slides. Next slide. This just looks at this as baseline, and these are people who either had partial gluten-free diet or strict gluten-free diet after 3 years, and many of the people on a strict gluten-free diet had increased bone density, and that was of the total skeleton of lumbar spine. Next slide. But over time, that may not be increased. And if you start on your gluten-free diet in menopause, you don't do as well to increase your bone density. Next slide. So how can you manage strict gluten-free diet, calcium intake, vitamin D, do a DEXA scan at diagnosis 1 to 2 years after a gluten-free diet initiation, routine treatment for osteoporosis. There's minimal data on tolerance in celiac disease, but in reported patients, there was no increased intolerance. And there was no data in this group on hormone replacement therapy. Next slide. I am going to, can we go to the next one? And this slide, which was my next to the last one, is looking at, this is a line showing a normal bone density, 15.7%. And this is looking at the spine with decreased density, actually minus T-score or Z-score. And this is in people at the femoral neck, and it's about the same in all women, men, premenopausal women, postmenopausal women, but this is not. Next slide. So this is a summary of celiac disease and menopause. There's premature menopause and fertile lifespan, often in celiac disease. It's twice as common to have decreased fertile lifespan. We will skip primary ovarian insufficiencies increased. Menopausal symptom severity is increased with hot flashes, musculoskeletal pain, and irritability. Age at menopause strongly correlates with bone mineral density in treated celiac disease women. 21% of celiac disease patients were diagnosed after a traumatic fracture. And gluten-free diet and bone recovery seems to be something that we see, and it is important to stay gluten-free and a strict gluten-free diet. Thank you.
Thank you so much for that, Dr. Wolf. We much appreciate it. It's my pleasure to introduce our third speaker today. Elizabeth Ward is a writer and nutrition consultant based in Reading, Massachusetts. She's a member of the Academy of Nutrition and Dietetics and of several of its practice groups, and was a national spokesperson for the Academy for 9 years. She has authored or co-authored 10 books for consumers about nutrition at various life stages, from prenatal to midlife and beyond. Her most recent book is The Menopause Diet Plan, A Natural Guide to Hormones, Health, and Happiness, which she co-authored. Thank you so much for joining us today.
Thank you for having me. It's my pleasure. Now, I'm going to have to go really fast because I have a lot of slides, a lot of information, but we can always talk more offline later. So in terms of my disclosures, I'm the co-author of the Menopause Diet Plan with my good friend and registered dietitian colleague, Hillary Wright. I'm a speaker and a consultant for the American Pistachio Growers and also for the American Fitness Professionals Association. So I just wanted to go over this, but we've heard a lot about this during our seminar today. Just about the timing. Perimenopause lasts between 2 and 8 years, and I'm going to keep coming back to that and you'll see why in a minute. And menopause is 12 consecutive months without a menstrual period, and pretty much everything after that, for our intents and purposes, is postmenopause. And we are going to talk about how postmenopause and preparing for it and making sure that we are doing everything that we can from a nutrition and lifestyle perspective is so important, because women can live 30 to 40% of their lives after their last menstrual period. And I think that there's a feeling out there that, once menopause occurs, your life is over. So that's one thing I hear, which is just not true at all, because we have so much more living left to do. And secondly, that, once you're done with the symptoms of menopause, it's kind of like, you're over it, and you're not. You have changed. Your body has changed, and we need to alter our diet and lifestyle to go with those changes. So one of my sayings is, you may be done with menopause, but it's not done with you. And so we need to adjust accordingly. So one of the topics that I get probably the most questions on is body composition and weight changes during the perimenopause transition and also in postmenopause. And so, I think if you look at the statistics, it might be a little bit alarming to hear that women gain an average of about 1.5 pounds a year during their 40s and 50s. And a lot of women come into the perimenopause transition already having overweight and obesity potentially. And that really does affect how they go through the transition and of course, their health during the transition and afterwards. But the question is menopause to blame? And, it gets a lot of blame on social media, which I'm on a lot because I do a lot of education around this topic. And that's where women are getting their information. So there's a lot about, your hormones being broken, your metabolism being broken, and a lot of also claims about how to fix that metabolism, and a lot of expensive, programs and supplements to go along with that claim. So let's take a look at whether menopause is to blame for weight gain during this time of life. So it's true, there are changes in body composition and weight during the menopause transition, and this is one of the studies out of the SWAN group, the study of women's health across the nation, which is 3,000 ethnically diverse women across the United States. Wonderful pool of data. And in this case, women were looked at over a span of 18 years, including 18 years after their final menstrual period. And what they looked at was the body composition during this time frame using the DEXA technology. Now, what they found was that during this transition, women lost lean mass and they also gained fat. And if you're a woman who's gone through this period of life, you probably are like, yeah, no kidding. I know, I've been there. But I think that the key words here that we need to really look at is lean mass, because lean mass is not the equal of muscle mass, of skeletal muscle mass, which is what we talk a lot about during the menopause transition, trying to maintain muscle mass and build it. Lean mass is only about 50% muscle mass. Still important, but we're not measuring the loss of skeletal muscle mass in this study. So there's really no proof that estrogen loss and other changes cause lean mass loss and fat gain. There is an association, but there's no direct proof. Still, it does highlight the fact that the body is changing during this period of time. And remember I said that could be anywhere between 2 and 8 years of your life, the perimenopause transition. So I think, if you take a look at the literature, you would come to the conclusion that it's not your hormones that are causing these changes. And yes, there is a slight decrease in lean tissue, which means that there's a decrease in skeletal mass and there is an accumulation of more fat. But is it actually the hormones or is it something else? And a 2026 physiology and behavior study found that accounted for age, accounted for body composition and physical activity, found that perimenopause and postmenopause were not associated with a slower basal metabolic rate, a BMR. Now, a BMR accounts for up to about 70% of all the calories that you burn during the day, and it depends on your body composition, genetics, lots of things. But the study did find that the more fat-free mass, the more lean mass, more fat-free mass a woman had, the higher her BMR. Now, in a 2023 study in the Journal of Clinical Endocrinology and Metabolism, that found that increasing age was associated with a decline in BMR in midlife women. And I think if you looked at men, you'd probably find the same thing, because as we age, we lose lean mass. As we lose lean mass, which includes skeletal muscle mass, our metabolic rate declines a little bit. So in this study, menopause wasn't related to the decline, and neither were levels of estradiol, sorry about that, the most potent form of estrogen in the body, or the levels of FSH. So it's probably not the hormones that are causing weight gain, loss of skeletal muscle tissue, loss of fat-free mass, but rather the aging process. And I mentioned before that the menopause transition can last upwards of 8 years. In some women, it may last 10 years. That's a lot of your life. That's a lot of aging going on. So we cannot dismiss aging. And when you're being told that you're broken, that it's your hormones, that there's nothing you can do, it's simply not true. There is one thing that we can blame on hormonal changes, and that is the accumulation of visceral fat, aka belly fat, which is the accumulation of fat underneath the abdominal muscle wall. We can blame that on lower estrogen levels. There is an association between those two things, but only when weight is gained. It's not like your fat cells, pack up their bags and move from your buttocks, your thighs, your hips to your belly. It's weight gain that's happening during this period of time when estrogen levels are declining. So you're getting that accumulation of visceral fat. And that's something that we don't want. Visceral fat is not good when it comes to inflammation. It produces inflammatory compounds that are going to aggravate any inflammation that you have in your body or cause new inflammation. But the good news about visceral fat is that it's no harder to lose than subcutaneous fat. Now, subcutaneous fat, if you take a look at this lovely depiction here, subcutaneous fat is the type of fat that you can pinch. I mean, it's like right under your skin. Whereas the visceral fat, you can't see it. You probably can't feel it except when you go to, put your pants on and you can't button them or something else doesn't fit properly. And you say, hey, where did this come from? So that is a phenomenon of lower estrogen levels plus a calorie surplus. So I just mentioned before, you're not helpless in this, and women are not helpless in controlling their weight during this period of time. And there is evidence that what is happening is that women are getting, during this period of time, less physically active. And if you look at, and I couldn't include it here because I don't have a lot of time, but if you look at data from the CDC about physical activity in different age groups in women, you can see it go down as age goes up. Same thing when it comes to resistance training, which I'm going to talk about in a minute. So we are less physically active during the decades of maybe the 40s and the 50s and even into your 60s. And that makes a real difference when it comes to weight control. So there's data out of the Monet study that followed women for 5 years through the menopause transition and found that, that transition was associated with less exercise and also less kind of daily activities, I don't know, walking a few extra blocks to an appointment, or getting out of the car instead of going to drive-through. So on average, in this study, women burned 200 fewer calories every single day. If that is not countered with a decline in caloric intake, then we are going to possibly have weight gain. So, do you need more NEAT? What is NEAT? Well, it's non-exercise activity thermogenesis. It's the calories that you burn from making every movement that's not sleeping, eating, or exercise. And higher levels of NEAT are associated with lower body weights in large population groups, and also with better health, lower blood sugar levels, and many other parameters of health too. Sitting is not good for you on so many different levels. I think we all know that. But it's the fact that we just kind of dismiss this type of activity. We think that we have to get into the gym and work out hard for 30 to 45 minutes, 7 days a week, and sweat in order to control our weight. And yes, I mean, moderate intensity activity is very, very important for overall health. And so is resistance training. But the daily activities of living are incredibly important. So all the things that you try to outsource, right? Like, chores, I don't like to do them. I don't know about you, but, vacuuming, cleaning the house, yard work, those things, they burn calories, and they are essential to weight control during this period of life and, before and after this period of life. So let's talk about muscle and menopause and what it means in terms of health and your metabolism. So we accrue muscle from birth until about age 30. And after that, it starts a slow and steady decline. And at about age 65, muscle loss really accelerates in men and in women. Now, most muscle is skeletal muscle. About 30 to 40% of your body mass is made up of skeletal muscles. So the muscles that help me move my arm, or when I want to get up and walk away from this desk, that's skeletal muscle. And muscle does burn slightly more calories than fat. It's not, a huge amount, but, keeping it on board or making more of it can affect your calorie burning capacity, but it's also an incredibly metabolically active tissue, and it plays a role in helping to reduce your risk for insulin resistance, which can lead to type 2 diabetes. It also helps to prevent frailty as you get older. So anabolic resistance increases with age, and what that means is that it's harder to make muscle as you get older, but we can still make muscle, and we should do that. And the way we do that is through challenging resistance training and also adequate calories and protein. And women need at least 1.2 to 1.6 grams of protein per kilogram, which is 0.54 to 0.73 grams per pound of body weight. And you also want to make sure that you're not on a very low carbohydrate diet to try to get that weight off, because you're not going to be able to make protein. Now, we've talked a lot about menopause and bone health. Estrogen supports bone health, and when you lose that, you run into the risk for thinning bones, especially after the first 5 years after your last menstrual period. And strategies to support health from a nutrition standpoint include getting enough calcium, vitamin D, vitamin K, magnesium, protein, because the matrix inside of the bone is made up of protein, and also fiber, because fiber is going to feed the wonderful bacteria, the beneficial bacteria in your gut. It's going to help you reclaim some of the calcium and magnesium from the colon. And from strategies to support bone health, exercise, weight-bearing exercise, walking, jogging, hiking, also resistance training, at least 2 sessions per week, because we really want to stress the bone and trigger bone cell production. Now, menopause does play a role in increasing your risk for cardiovascular health. When you lose estrogen, your LDL levels go up, and that is problematic because of narrowing arteries and restricting blood flow to the heart, brain, and extremities, and also lowering your HDL levels as well. And HDL is protective against clogged arteries. Menopause also, the loss of estrogen increases blood pressure. Arteries become stiffer and thicker with age, and that causes your heart to pump harder. So when it's really not very well controlled, it can lead to heart failure long term down the road. Hot flashes, we've talked about vasomotor symptoms. 80% of all women experience them. They are linked to a greater risk for cardiovascular disease. So if you have them, I'm just going to skip this study. If you have them, you really need to talk to your doctor about them, because there's a relationship between vasomotor symptoms, higher blood pressure, insulin resistance, and type 2 diabetes, poor lipid profiles. It's not a good thing. So definitely talk to your doctor about it so that there's more vigilance about your risk. Digestive health. Microbes make up 1 to 3% of your total body mass. Most of them live in the gut, and most of them are bacteria and beneficial. And so we've heard a lot about beneficial gut bacteria. So because I'm short on time, I won't go over all of these things. But we want to make sure that we're nourishing the gut, because the gut is going to, of course, the microbes in the gut are going to protect the gut itself, but they are going to protect the entire body in so many ways. So the estrobolome, Dr. Wolf talked about this. It's a collection of gut in the bacteria in the gut that metabolizes estrogen. We want the gut to be as healthy as possible so that we can maximize potentially getting some more estrogen back into the bloodstream to possibly help reduce symptoms. In terms of hormones and gut function, you did hear a lot about this before, but declining estrogen and progesterone may cause your gut to become sluggish. So you have more constipation and more bloating. Also, increased permeability of the gut barrier, which means that some things may leak out and cause more inflammation into the bloodstream. So I'm just going to simplify, really simplify the talk about fiber. There's soluble fiber and insoluble fiber. Soluble fiber is fermented by gut microbes. The sources include plant foods, helps to contribute to a feeling of fullness as well. And the insoluble fiber in plant foods, that doesn't dissolve or get fermented, but it does help to prevent constipation. So the suggested fiber intake is about 14 grams per every 1,000 calories. So it's based on calorie intake. There are no separate guidelines for soluble and insoluble fiber. And the reason for that is because the reason for that is because there's a mixture of both types of fiber in all foods. So this is the getting to the end. I know I'm short on time, but what is the best gluten-free menopause diet? Well, there is no single best diet for everybody. Plant-based, but not necessarily free of animal foods, providing adequate high-quality protein and other nutrients, curtailing refined carbohydrates and including fiber, promoting promoting heart health by swapping unhealthy fats for healthier versions, lower in sodium and saturated fat and added sugar, and of course, gluten-free supplements as necessary. So here's the last slide that I have. I'm a big fan of multivitamins because they can fill in small gaps that may result in chronic conditions. So vitamin B12 for those on protein pump inhibitors. And also, as we age, we need more synthetic B12 from supplements and also enriched foods, and also the vitamin D. There's usually a good amount of vitamin D in multivitamins. Speaking of vitamin D, you may need more vitamin D than what I have up here on the slide based on your lab. So that's something to work out personally. Omega-3s for those who don't eat at least 8 ounces of fatty fish a week, very good for your heart. Women don't get enough omega-3 fats. Don't take very high doses though, unless you're under medical supervision. And always, always, always tell your doctor and your dietitian about all the supplements that you're taking. And just briefly, I have something in here about choline, which supports liver, muscles, cell membranes, neurotransmitters, what goes on in the brain. Then the highest amounts are found in higher protein foods. Women do not get enough of choline, and if you need more, go with the choline-free, gluten-free choline by tartrate supplements or other choline salts. And of course, calcium, if your dietary calcium is insufficient or if you need more per your practitioner, then you really need to consider that, because as you pass menopause, the requirement does go up because you have lower ability to absorb it. So that's all I have compressed into a very short period of time.
Amazing. Thank you all so much. We'll now shift into the Q&A portion. Thanks to all who submitted questions ahead of time and also during the talk. To kind of get us started, I was hoping to discuss a little bit more non-hormonal ways to control hot flashes and other symptoms. There's a lot of interest in that.
Happy to answer some of that that are non-hormonal options. So there are a few different categories of both pharmaceutical and non-pharmaceutical options for the management of vasomotor symptoms that are outside of menopausal hormone therapy. There are some what we call lifestyle modifications that for some patients can really help, I would say, the intensity of vasomotor symptoms. They're not really a treatment because there are a lot of things that can trigger your hot flashes to be worse. Including, that are environmental. So of course, being in a hot room is going to only make your hot flash a little bit worse than what it would be if you are in a cold room with a fan on. When patients are sleeping, wearing really tight clothes, there's something about the rubbing on the skin that then triggers the area of the brain that triggers those hot flashes that makes it worse. So we encourage patients to wear very loose clothing. We know things like stress actually worsens hot flashes. My classic example are patients of mine who are teachers, where their hot flashes and night sweats are much worse during the school year and not as bad in the summer, even when the summer months are hotter. So we know stress management is a big part as well. But I can't stress enough about this part is that, again, this is not a treatment, I would say, for hot flashes. So, don't let anyone tell you oh yeah, have less stress, your hot flashes won't be so bad. Not at all. It just may help not intensify them a little bit. There are some marketed supplements out there, and I will be very honest, and you can get a lot of different opinions about this. I have a little bit of a love-hate relationship with supplements. There are some natural products out there that for a lot of patients does help some of their menopausal symptoms, including things like black cohosh or St. John's wort, rhubarb extract, ashwagandha, which for a lot of patients really do help them. And I will say that is a little bit more for patients with more mild symptoms rather than the patients with a lot more intense vasomotor symptoms. The reason I say I have a love-hate relationship is that while they really do work for a lot of patients, supplements are just not regulated in the same way. So like I tell my patients, like I can't guarantee everything you're getting in that supplement is what's really written on the bottle just because they don't have that same rigorous regulatory standard of what they can put in for fillers. So I'm very transparent about that. There are some pharmaceuticals that are available also for the management of vasomotor symptoms. There are a couple of medications in the antidepressant family that have been shown to decrease hot flashes and night sweats. There are two what we call SNRIs. The two that are out there are called venlafaxine and paroxetine. They are marketed under the brand names of Paxil or Effexor, that have been shown to reduce hot flashes and night sweats in, I'd say about 50% of patients who try them find a response to it. So it's not amazing, but some people do find that it works well for them. The last family of Medicaid, there are a couple other like unique ones that work for some patients. I'm not going to spend too much time so we can answer other questions. But the last family of medications that I will mention are what we call our NK antagonists, which are two game-changing newer generation medications that have come out in the last like decade. You may see commercials actually about them now on TV, and they're branded under the market names of Veoza and Linkuit. I really just want to tell you how they work because it's actually kind of fascinating. So normally one of our thermal regulator centers in our brain actually sits right next to what we call our GnRH pulse generator. So that generator is what triggers our hypothalamus, a little gland in our brain, to stimulate hormone release that then goes and triggers our ovaries to make estrogen. Okay. When you are menopausal, that generator is like firing constantly because our ovaries are like, yo, we've retired. We're not making this estrogen anymore. Our brain is like, ovaries, wake up, make more estrogen. And so it's just firing away. That firing away goes right next door to where our thermal center is with this family of nerves that then also now auto just like goes off, triggering our thermal center to go haywire. So what this new family of medication does, which estrogen used to do, it actually goes into that center of the brain to quiet those nerves. So it goes directly into the center to help quiet the nerves that are triggering our thermal center to go a little haywire. So it works really well. About 70 to 75% of patients will notice a significant reduction in their hot flashes and night sweats. There's some secondary data to be determined, but very promising on its effect on sleep as well, and whether that can be used for sleep disturbances alone without vasomotor symptoms. And it's a great non-hormonal option for patients, or it's just a great option for patients who just want to try it, who don't have the other symptoms. So it's definitely worth talking to your provider about because the success is pretty good.
I wanted to just make one comment on talking about a lot of women as they get older get cramps in their muscles. Magnesium's helpful for that. Watch out for magnesium oxide, hydroxide, or citrate, as that can give you diarrhea. There's also a magnesium compound where you can put it as a cream. It gets absorbed through the skin. The second thing is creatine, and you can comment on that, but there was a recent study looking at safety in postmenopausal women and increase in muscle mass. And I think that it appears to be safe. It's 3 to 5 grams per day. Again, you don't know what you're getting in the over-the-counter preparations and if it's real, so you have to sort of investigate that. But those are two other options, I think, as we're getting older.
What I would add to the creatine, because you're absolutely right, Dr. Wolf, there has been actually pretty excellent data about its increase in muscle mass when used, especially in perimenopausal and postmenopausal women. The first thing is like the standard dose is about 5 grams, but you definitely want to start at about 2 to 3 grams if you're just starting because it causes very significant water retention and bloating. And you have to drink a ton of water when you use it, I would say. And you have to do that in addition to actual strength building. Like you can't just take the creatine alone and not add the like strength training that kind of goes with it. But I definitely would say that the start small and then slowly build your way up, especially because of the really severe bloating that can happen because of water retention, because it can affect. And while some of this data was seen a little bit more in men, there was a little bit of diarrhea, I think, associated with over creatine use. So again, just be kind of cognizant about that. There were some also newer studies about how it helps with brain health in higher doses, but closer to the 10-gram mark. But again, you want to really build that slowly. But it's an old supplement. It's been around for a very long time. People always think of it as like a bodybuilding supplement, but actually it's a lot. Its safety is actually pretty good for the vast majority of patients. Just you have to drink a ton of water with it, like a ton of water.
One other thing people should keep in mind, as we get older, we get shorter and our bellies go out. So if you have the same amount of fat that you had and muscle mass or less muscle mass in your belly now, you will notice that you look more distended. It's not always bloating. I think there are also some data looking at the difference in the fat cells in visceral fat versus fat in your legs, etc., and they're very much more active and is important in gestational diabetes also. So I think we'll hear more about that and the effect of that on perimenopause and menopausal women.
Absolutely. A lot of great information. Thank you all for this. Sounds like we'll have to do a second part for this webinar, maybe next year when we have a little more information about all of that. I know we're getting close to wrapping up, so I just wanted to finish with a question, I think, for you, Liz. Partially to speak a little bit more about if there's any specific, I know you talked about protein recommendations, but for different age groups. And then specifically, we got several questions about women who either have diets who are light in fish and meat or who follow vegetarian or plant-based diets and how to factor that in, recognizing those are big questions. So maybe we'll do a rapid fire answer and also pin that in for the next one.
Okay. So the recommendations for protein are for adults. So it's 1.2 to 1.6 grams per kilo, which is, let's say, in the higher end, about 0.7 grams per pound of body weight that you should be eating in terms of protein. And, you know, I talked a little bit about anabolic resistance, but I didn't really have the time to go into it. As we get older, like anabolism or, anabolism is growth, right? So anabolic resistance is that resistance to growth. And as we age, we are more resistant to growth. We're not in the growth phase, but we're trying to get our muscles to grow, right? So the idea is that the research shows that if you throw a little bit more protein at that muscle protein synthesis process, you can help to overcome anabolic resistance in conjunction with challenging strength training, at least 2 sessions per week for all adults. So it's not like, you know, your protein needs change as you get into your 60s. It's one thing, 70s, 80s. It's a matter of just getting into a routine, getting that protein in, getting that resistance training in, and continuing and rolling with the punches. Things happen to people. Diseases come along, conditions come along, whatever. We need to roll with the punches. If you are not consuming a lot of animal foods, it's very, very individual. I don't have a pat answer to that because it depends on which animal foods you're not consuming in terms of what nutrients you're leaving out. And that's something for you to work out with, a registered dietitian in order for you to get all the nutrients that you need as well as the protein that you need as you age.
Wonderful. Thank you. I think that may be all the time we have for questions, but thank you all so much.
Yes,
thank you.
And thank you, Dr. Olshan, and thank you to all of our presenters and attendees for your participation today. We hope that all in attendance found this webinar educational and helpful. Please note, if you registered for the continuing education units by following the instructions that were presented to you in the chat box, those units should be received in the next 2 to 3 business days. Also, remember that this recording of the webinar and all past webinars in the All Things Celiac series can be found at nationalceliac.org. We encourage you to keep an eye on the Harvard Medical School and National Celiac Association websites and social media accounts for updates and additional information about the timing of future All Things Celiac webinars. And on behalf of all of our esteemed guests and from all of us here, we look forward to seeing you next time, and thank you for your continued support.